Assalamu alaikum. Good morning, everyone. My name is Dr. Hassan Ali. Today, I'll present the article on post-wide dribbling. Post-wide dribbling, or also known as post-micturition dribbling, it can be defined as the name given to the problem when patient experience an involuntary loss of urine immediately after they have finished passing urine, or usually after leaving the toilet. It's very embarrassing and bothersome complaint we urologists encounter in clinic that affects severely quality of life. It affects the quality of life in different aspects. Practical aspects, if we discuss, then patient is difficult in managing routine and job work. Patient often hold up urine for long time and prefer to void at home. Often have multiple washroom visit and sensation of discomfort during routine work. Social aspects, patient is usually afraid of embarrassment. It's case of spotting of clothes with urine, avoid gatherings and long travels, difficulty in using public toilets, especially if he uses any manure for urethral emptying. Religious aspects, unable to maintain ablution, difficulty in performing prayers, issue with cleanliness of clothes. And we in our clinics we most of the time see patients whose primary concern is missing of prayers due to lower urinary tract symptoms or post-wide dribbling. When we come to prevalence, Boston area community health back study that involving more than 2,300 people aged between 30 to 79 years in United States reported prevalence of 8.7% in men. And in different countries, the prevalence data varies and age variation also exists. It's more common in male that present in lower urinary symptoms clinic with voiding symptom than the storage symptoms. And in most studies, prevalence is proportional with advancing age. As the patient age advances, the symptoms become frequent. Regarding pathophysiology, mechanism is not clearly understood yet. There are two proposed mechanisms. One is the weakness of pelvic floor muscles, especially the bulbocavernosus and ischiocavernosus. Contraction of pelvic floor muscles emptying residual urine from urethra and at the end of urination, which we call a milk out. In case of weakness of pelvic floor muscles, results in poor milk out, leading to urine residue that emptying after micturition. Another proposed mechanism is incompetent external urethral sphincter. At the end of urination, external sphincter contracts and urine that remain in prostatic urethra is then drawn back into the bladder. That's called milk back. In case of incompetent external sphincter, it may result in poor milk back after urination. Urine then fall into bulbar urethra and leading to urine residue that results in post-void dribbling. On the basis of this proposed classification, the author has categorized these symptoms into three categories. The category 1, in which the urine trapped in penile urethra, known penile urethral urine trapping. In category 2, prostate urethral urine trapping, or in category 3, idiopathic bulbar urethral urine trapping. These are three categories which we further discuss. Category having defined urethral pathology and urine traps in urethra which slowly drips out of urethra after micturition. It begins immediately after voiding and continues till urethra empties. Recent data showed post-void dribble is important symptom in 73% of men with urethral stricture. Causes that fall in category 1 may be phimosis, meatal stenosis, urethral stricture, urethral diverticulum, and other causes urethral tumor or polyp or stone. The category 2 is prostatic urethral urine trapping. In this category, the author said urine trap between the internal sphincter and the external sphincter. And dribbling occur typically after few seconds or minutes after toilet when patient after voiding when patient leaves the toilet. The causes that falls in this category are bladder neck hypertrophy, benign prostatic hyperplasia, chronic pelvic pain syndrome, and sphincter dyssynergia. Category 3 is idiopathic bulbar urethral urine trapping. In this category, mechanism involves some form of neuromuscular dysfunction. There is no defined pathological cause. There is functional structural cause. There is functional cause. Video UDS identified group of men with post-void dribbling in whom urine temporarily trapped in bulbar urethra. And dribbling in this category also occurs mostly immediate after voiding. The causes in this category is bulbourethral neuromuscular dysfunction. Since there is no any organ structural cause, there is neuromuscular dysfunction. How we will evaluate the patient? Then first of all, proper history, age. In age, we particularly focus on the time of onset. Patient is having these symptoms. Start at which type of age? Sex, since it is more common in males, and patients lower unit symptoms. There is a predominant storage symptoms or voiding symptoms. Timing of dribbling after urination, immediately after voiding or after few seconds or few minutes. History of urological pain, any pelvic, perineal or suprapubic pain. History of passage of stone, genitourinary or instrumentation. History of some pelvic surgery or sexually transmitted disease, urinary tract infection, or structure or BPH. In examination, we will grossly assess the pelvic, the bony structure of pelvis, any surgery, abnormalities of external genitalia, like we already discussed the phimosis or urethral some problem. Urethral examination, any plaque or stone. Abdominal examination, any surgical scar or what is the condition of bladder, it is palpable or not. Spinal examination, is there any spinal anomaly? DRE, we will see the condition of prostate or any surgical scar. In investigation, we will first do the baseline urine DR and culture sensitivity to rule out infection. Ultrasound KUB to see any stone and degree of hydronephrosis or patient is having any pre-void and post-void volume of urine. X-ray KUB to see any ureteric stone. In MRI spine, we will see any spinal pathology that is causing patient having these symptoms. Uroflowmetry, we will assess the any obstruction in the lower urinary tract or and patient Qmax and post void residual. Antegrade or retrograde ureterogram to rule out any stricture. Transrectal ultrasound to assess the volume of prostate in case of BPH. Micturating ureterogram. In cystoscopy, we will see the any pathology in urethra like stone or stricture or capacity of bladder. Video urodynamics, we will see the dynamics of the bladder sphincter. Another. When we will come to the management, there are four main things. The number one is treat the underlying cause and pelvic floor exercises, bulbourethral massage, and a few strategies that we can tell the patient to use. In category 1, as we already discussed, the causes are phimosis, meatal stenosis, stricture, diverticulum. Then if there is phimosis, then we perform circumcision. In case of meatal stenosis, meatoplasty. Urethral stricture, depending on the location of the stricture, we can do direct vision internal urethrotomy or dilatation or urethroplasty. In case of urethral diverticulum, we will reject. Another cause is in case of urethral stone, cancer or polyp, then surgery for specific condition. In category 2, the causes were bladder neck hypertrophy. Then we can use medical management like alpha blocker or bladder neck incision. In case of BPH, medical and surgical management depending on the volume of prostate. Like we can, and in chronic pelvic pain syndrome, alpha blockers, antibiotics, anti-inflammatory, and pain management. In case of sphincter dyssynergia, then we will use physiotherapy and a biofeedback mechanism. We can improve the dyssynergia in patients. In category 3, that is bulbourethral neuromuscular dysfunction was a cause. Then management will be urethral milking maneuver and penile shaking maneuver, urinal wait time strategy, and pelvic floor exercises. There are some pelvic floor exercises. The most important is Kegel exercise, and second is squeeze and release, and squats. Pelvic floor exercises are specifically targeted to bulbocavernosus and ischocavernosus muscle, as we discussed in pathophysiology that these two muscles are important in emptying of urethra. They help to place pressure on urethra and empty residual urine. Effect depends on the degree of weakness. If muscles are more weak, then the result will not that much beneficial. And if they are mild degree of weakness, then patient symptoms will improve. More effective than bulbourethral massage, but it is difficult to learn. Take longer time in adequate effect. Usually their effect come in 3 to 6 months and may need supervision for better results. Bulbourethral massage is the simplest and self-help technique to relieve post-micturition dribbling. We taught the patient to place his finger behind the scrotum after urination and massage his bulbourethra in forward and upward direction toward the penis until the residual urine come out of urethra. Patient may need to repeat this technique several times after voiding to empty his urethra. Strategies: main guard. These are pads which can patient use with, to prevent soakage of its cloths. Penile shaking that help in emptying urethra, urethral milking, and urinal wait time. The patient should wait after for few minutes or second after voiding, so his urethra completely empties. Summary: wet pads after urinating is familiar complaint for urologists. At least three mechanisms of post-void dribbling exist. Number one, stepping of urine in either penile, prostatic, or bulbourethra. After a standard investigation, patient diagnosed into one of three categories, and management based on these mechanistic classification will lead to improved treatment. And more research definitely needed for these bothersome lower genetic symptoms for better outcome. Thank you.
You see, it is again very interesting. And as urology progresses in uh, every part of the world, uh, the part of the urology that deals with men, especially, it is now known as men's health. For instance, in the context of men's health, what we do here in our unit is only one clinic, and that is prostate clinic.
Prostate.
So, men's health or female health, it is beyond something which is related to only one pathology, and that is, for instance, in females, if you want to discuss the causes of incontinence on dribbling, then there are other a wide variety of causations. Similarly, the same story goes for men's health, because there are many aspects of proper living of a male person that becomes jeopardized as the age progresses. For instance, there are certain conditions which can affect a person in early, maybe in early childhood, in the middle age, as well as in the geriatric group. So it depends upon the widening of horizon for the whole topic, and that is urology. Uh, we have now come up to a stage in SIUT in the last 25-30 years that we can recognize a separate clinic for for different things. For instance, for prostate, which was formulated in the mid 90s, prostate clinic. Then recently, what happened was we have devised another clinic, and that is neurourology clinic of functional urology. But it caters to both males and females. Now, I think now is the time for the younger generation to take up the lead, and maybe they can suggest another clinic, which might be a bladder rehabilitation clinic or a clinic which deals with such problems as dribbling. Uh, why I'm saying it is because as the time goes on, age is increasing. We have got now population which is 60 years plus, and they are in greater number. When prostate clinic was started in mid 90s, there were only 20 patients in the first clinic, and now there are more than 450 patients in a single clinic once a week. So why we are having so many of patients? Maybe because of the reason that the population is increasing, maybe because of the reason that now awareness is also there and people do come with their problems. But the third point is very important, and that is we have gone on to a stage where our standard of living and the standard of health is such that we are having more older people, and when we have got more older people, then the package of diseases comes with the old age also comes up in greater numbers. So the challenge is for us, the question is for us, these specialists who we are all specialists in a particular field. So we should categorize them, as you have rightly pointed out. We should devise some strategies which are there in literature. And every country, every part of the world goes through this evolutionary process of understanding and dealing with problems of the society. So we have now reached, as I have said earlier on, we have now reached a stage where we can, whether we like it or not, we have got a lot of patients and they need something from us. They need some strategies, some treatment protocols for their problems. For instance, if somebody comes to me with this problem of dribbling, then as a urologist or as a urologist of maybe the last century when I was being trained, I always think of what's the age of the patient, whether the patient is in 50 years plus age or 50 years minus age, and what kind of problem he might have. For instance, if the person is greater than 50, I will always think about prostate and dealing with prostate, whether maybe there is a background of diabetes mellitus or some CVA, Parkinsonism, things like that. So I straight away move on to something called urodynamics and try to figure out where my patient is and how I should deal with him. If the patient happens to be less than 50 years of age, then what I would like to think about is nothing. I would this problem with certain medications, and there are only two kind of medications. One is the alpha blocker, the other one is the anticholinergics. And these are the only two drugs or the classes of drugs with which we can do away with any problem, whether it's of younger age or older age. So europharmacology is also advancing, but it is not advancing so rapidly that we have got answer for every question from pharmacology side. So we might be able to look up to our colleagues in, again, physiotherapy department, because their subject is too wide a subject. What they can do or help us and help our patients is in terms of something which is called physical. It's the physical exercise. It's the physical structure of the hammock. It's the physical structure of the pelvic diaphragm. It's the physical tone of pelvic muscles. If that aspect is only taken care of properly, we'll be able to solve a lot of these problems. The second thing is there are other aspects which come into play together with the help of a physiotherapist, and these are, for instance, biofeedback. Now, biofeedback is not something which is new. Biofeedback is here in this urology setup for the last, I think, 3 decades. It was introduced in early 90s it was it moved on to its pinnacle in around 2000 2001, and now it's pretty common to have this kind of treatment for a lot of patients. Again, with increasing age and geriatric population, we might use it for many questions. So these are the kind of um, I don't call it a change in our thinking process, but this is something which we are confronting more and more, and I think we should start thinking about it.